Hi, everyone, and welcome to Henry Schein's webinar series on COVID-19. I'm Dr. Gary Severance with Henry Schein, and it gives me great pleasure to turn it over to Dr. David Reznik, who's going to give us the latest update on COVID-19 and dentistry.
Good day and welcome again to our clinical update on COVID and where we stand. We sort of have a mixed week with some increased cases, but we also have some wonderful news that hopefully will help us start on our return to normal. And I think that's what we all are looking for. How do we get our practices back to normal, back up to full speed? How do we get our lives back up to normal, back up to full speed, so we can do the things that we enjoy doing and really maintain some precautions, but also be more normal about it. So let's start off with where we are with the epidemic. This is not going to be some good news. If you've turned on the television lately or looked at a paper or looked at your computer, you can see that we're literally at an all-time high with the number of cases that we're seeing. We've had several days of more than 100,000 cases per day. If you look at the chart, you can see we did have one bump in July I talked about a few weeks ago, then things starting to settle down in September. And now if you look at the end of October and what's continuing into November, you can see that we're really in the midst of another wave or a big wave of COVID. So we have over 10 million cases in the United States. Our deaths are getting close to 245,000 at this point. Regretfully, Texas has taken the lead and is the first state in the country to have more than 1 million cases. Texas has, as of today, actually, Texas has 1,010,000 cases with reported about 19,000 deaths. California, 958,000 cases. Florida, 827,000 cases. New York, 557,000 cases. And you can see Illinois. A lot of these are bigger states. There are bigger states that have very big metropolitan areas, and that helps explain to a degree why these states, which are very populous, are seeing this kind of numbers. But remember, I've been talking about friends and family I have in Wyoming and how that state has done a great job and they really haven't seen many cases. I regret to inform you that now Wyoming is in the midst of their own COVID crisis. So this is impacting people no matter where you live around the United States. The map I'm showing now just basically shows you where we have our confirmed cases. And there are very few places in the United States that don't have outbreaks of COVID at this point. So that's just something, this is where we are today without using a vaccine, without having really some treatments that we'll talk about, but these are just our confirmed cases. If you look at where we are as far as patient volume levels, again, that's going to depend a great deal on where you live. We've been holding steady for around 80%. Sometimes it goes down a little bit to around 78%, or about 80% of normal. The number of practices reporting business as usual, though, has dropped from about 48% in early September to closer to about 40%, 39% in late October. So we've seen that there has been a drop. But there have been a lot of things going on in the world, and that could be a part of the explanation of why some of our practices aren't seeing as many patients. I work in a public health program at a very large hospital. We're seeing the opposite. Patients are now being more comfortable coming in. We are actually developing a wait list again. Our schedules are full again. Are we seeing the same number of patients? Well, after an aerosol generating procedure, we are letting the room set. But I am so comfortable with the equipment that I have purchased, the extraoral aerosol vacuums, which I really am a great believer in. The Aegis unit that I use has a large cup, and what we're doing is we're looking at splatter on face shields, and right now we just don't have any. We have HEPA filters in every room. So really talk to people that are much more knowledgeable than I am about dental technologies, your sales people, and really get and create a really good, safe environment. And that's what I feel we have, which is why we're moving forward. We are doing procedures now. Our hygienists have the relief system, and they have their own Aegis vacuum station. So everybody has a tool that's going to make it safe for patients, for staff, for people who come and visit our program. So the whole goal is to provide the safest dental visit, and I'm pretty confident that we're doing that in our program. And when you communicate that to your patients, then they feel more safe and they're more willing to come in. And this is a part of routine life. Never forget that oral health is a really important part of systemic health, as was in the old Surgeon General's report, which will be in the new Surgeon General's report of oral health in America. You cannot be healthy without oral health. So we're sort of in a new normal, but we're in a new normal for now. As advances take place in medicine, we're going to see increases in a new normal. Our new normal will get better and be closer to our old normal. That's what we're really trying to get to. So, location matters. And when you're in the bigger cities where you have more crowded folks, so the 20 largest cities reported lower patient volume numbers. On average, patient volume in cities is about 75% of pre-COVID levels. My clinic, we're about 85% at this point, so we're a little bit ahead. Patient volume is slightly above the national average in rural or smaller urban areas. Again, my clinic is in Atlanta. It's in downtown Atlanta, so I'm in a large urban area. But non-urban areas are experiencing patient volume at 83% of COVID-19, pre-COVID-19 levels, and smaller urban areas are at 80%. Now, I worry about how other things impact the disease. For instance, we know that there's a hurricane that is developing that's going to hit part of South Florida, part of the Tampa, part of maybe even to Jacksonville and impact Georgia. And when you have a weather event, it's staying safe and having other things that are impacting your daily life makes it a little bit more difficult. In our dental environments, it won't change. As long as we have power and we have our equipment, we're going to be fine. What concerns me is what happens when people aren't at work and when they're at home and barriers that they face. And so we really need to concentrate on providing healthy environments, not just when the patients are in the dental clinic or the dental office, but also promoting a healthy lifestyle when they're not. And we've been doing that for years, avoiding sugar, avoiding cola, brushing your teeth twice a day, all the different things that we do as preventive measures, now making sure that you protect yourself against COVID. Dental offices did add some jobs. It was about 11,000 jobs in October. As you can see, the recovery is a bit sluggish. But really what's important is in April, in the very beginning of this, healthcare jobs really took a beating and declined by about 1.4 million, with dental offices leading the way with a loss of over 500,000 jobs. So while the industry did see job gains in May and June, sort of healthcare employment has leveled off. And then the healthcare industry, my hospital stopped doing some of the non-emergency procedures, which are also income-generating procedures. And now, how do you deal with the resurgence of COVID when you're trying to open up for other services? So we're really at a balance in our healthcare system. Some areas are being overwhelmed, some areas are not. And it's just trying to stay healthy during this period of time, because we do face a challenge now. We're getting ready for flu season, and we'll have flu season and COVID season at the same time. So it truly is important for everyone to get their flu shot. If you look at the case definition, we've always sort of concentrated on, 3 or 4 different things. But the CDC did come out with an interim case definition, and I really have never gone over it with you, so I thought I would take the chance to go over it with you today. In the absence of a more likely diagnosis, at least 2 of the following symptoms need to be incurred for there to be a clinical criteria of COVID: fever, chills, rigors, myalgia, headaches, sore throat, nausea or vomiting, diarrhea, fatigue, congestion, or runny nose. Now remember, it's hay fever season too, so some people are going to have congestion and runny nose. Some people with the weather change will have myalgias. But if they have 2 of these, it could be a case definition. Or any one of the following: a new cough, shortness of breath, we've talked about that for quite some time, difficulty breathing, new olfactory disorder, not being able to smell, new taste disorder, not being able to taste your food. And to be frankly honest, if you can't taste food, eating loses its pleasure, and we could see some issues there. Or you could have a severe respiratory illness with at least one of the following: clinical or radiological evidence of pneumonia or acute respiratory distress syndrome. So you could look at certain symptoms, have at least two of fever and chills, myalgia, headache, sore throat, etc. Or you could have one of the following critical symptoms, such as cough, shortness of breath and difficulty breathing, a new olfactory disorder, new taste disorder, or you could actually have a clinical radiographic evidence of pneumonia or acute respiratory distress syndrome. If we look at the interim case definition, there's also lab values that we need to look at. And so the first is confirmatory lab evidence is the detection of severe acute respiratory syndrome coronavirus 2, what we call SARS-CoV-2, looking at their RNA in a clinical or autopsy specimen using a molecular amplification test, or PCR. There is presumptive laboratory evidence when detection of SARS-CoV-2 by an antigen test in a respiratory specimen. So not just an antigen test, but an antigen test on a respiratory specimen. And then there's supportive laboratory evidence, detection of specific antibodies in serum, plasma, or whole blood, some rapid tests, or detection of specific antigen by immunocytochemistry in an autopsy specimen. So the terms confirmatory, presumptive, and supportive are categorical labels that are used to standardize case classifications for public health surveillance. We want to know where the disease is and how fast it's moving. These terms should not be used to interpret the ability, utility, or validity of any laboratory test methodology. So I'm not saying one is better than the other. These are just public health measures that I'm trying to make you aware of. One or more of the following exposures prior to 14 days. So close contact, remember that changed. Close contact used to mean within 6 feet for 15 minutes in a row. Now it's within 6 feet for 15 minutes over an extended period of time, over 24 hours. There are factors that really go into the exposure level. So in the setting of an aerosol generating procedure, which we're all involved with at this point, without having proper protective equipment on, it may be defined as any duration. So my point there is make sure you have your eye protection on. The glasses that I am wearing right now are not eye protection. I would either need to have goggles on or a face shield on. And when we look in our hospital, we're so good at protecting our eyes because of being dentists and everything that we've done, basically because of the standard precautions that were put in place after HIV. We always have some kind of eye protection on. We have the proper masks on, but our medical colleagues are not wearing eye protection, which is putting them at risk. And so that is something that if you have friends that are in medicine, please make sure they're wearing eye protection. One of my dearest friends is an ear, nose, and throat surgeon. And when he would do his exam, he didn't used to have a mask on. And I would actually give him quite a difficult time about that because we do some research projects together. Basically, at the beginning of this, I went to him and I said, you really need to start wearing an N95 and real eye protection, anything I can do to help. And they have really changed their processes way back. So that's important to know. But again, if you have medical colleagues, let them know what we're doing to protect our staffs and our patients and things that they could do to protect themselves and their families. I think that's really important. We do not really have enough data to precisely define the duration of exposure, and there are things that we don't know, such as what is the level of viral load, how much of the exposure is there, things that we'll get to a little bit today, but it really does, there's different kinds of exposures. And of course, one of the other exposures in 14 days are member of a risk cohort as defined by public health authorities. So people who are 65 and older, people who have underlying medical conditions. How do we distinguish old cases from new cases? Well, repeat positive tests for COVID-19 using a PCR or molecular amplification detection within 3 months of the initial report should not be counted as a new case. And that is really important because we have non-infectious viral particles that could persist that PCR can pick up. To date, there has been minimal evidence of reinfection amongst persons with confirmed COVID-19 infection and growing evidence that repeat RNA tests do not correlate with active infection when viral culture is performed. Similarly, the experience with other coronaviruses that reinfection is rare within the first year. So you will hear about case reports. This person may be reinfected. That is different than communities. It's different than population levels. And at population levels, we're just not seeing reinfection, which is good news. When we look at case classification, we have to meet supportive laboratory evidence. And what that means is for suspect cases where we have a positive serology only, jurisdictions may opt to place them in a registry for other epidemiological analysis to investigate or determine probable or confirmed status. So did somebody have this disease in the past and now you're detecting viral particles? Probable cases meet clinical criteria and epidemiological linkage with no confirmatory laboratory testing performed. So it meets presumptive. So we have people in the hospital who are presumptive under investigation. So presumptive laboratory evidence meets vital records criteria with no confirmatory lab evidence for SARS-CoV-2. So we get the lab test back. They're no longer under investigation. We can dismiss, or if it's positive, then we deal with it as the positive case. Confirmed cases meet the laboratory criteria, and that's important. So we have confirmed cases meeting our lab criteria. There are several references I have here for you. We do, on occasion, make these slide decks available. If you'd like to do further research, here are some sources for what I just spoke about. What about chronic COVID? We're starting to hear about chronic COVID, and this was an interview that was done with Dr. Fauci, who I've actually known since, I guess I first met Dr. Fauci when I was on the President's Advisory Council for HIV and AIDS, when they announced PEPFAR, the President's Emergency Plan for HIV. I met him then, and then when I was in charge of domestic HIV for the President's Advisory Council, I got to work with Dr. Fauci on a regular basis. And I will say he is an incredible scientist. He's incredibly brilliant. And I don't know how he's been able to do it all these years. I'm really impressed with what he's been able to do. So he does refer to these as long COVID or chronic COVID cases. There's a program in Bethesda where the NIH is located. And if you've ever been to the NIH campus, you'll see how enormous this is, where they're looking at a large cohort of post-COVID survivors. So someone who had COVID, is cleared COVID, and we're looking at them. And what they're seeing are variable percentages in anywhere from 25 to 35% or more having lingering symptoms, well beyond what you would expect from any other post-viral syndrome like influenza, the flu, or others. One study of 143 people with COVID-19 discharged from a hospital in Rome found that 53% had reported fatigue and 43% had shortness of breath, an average of 2 months after their symptoms started. So again, these are just things that we need to be aware of, and hopefully a little bit of a means for us to protect ourselves from getting it in the first place. A study of patients in China showed that 25% had abnormal lung function after 3 months, and that 16% were still fatigued. So we have the well-described symptoms of fever, cough, loss of smell, and other effects that we talked about earlier in today's webinar, including fatigue, rash, headache, abdominal pain, and diarrhea. People who develop more severe forms of the disease also can report confusion, severe muscle pains, cough, and shortness of breath. So those are our folks who are in the hospital, either getting some kind of oxygen or ventilation. They tend to have some more symptoms. So this is a slide from the CDC that shows that COVID-19 is a complex illness that might, always a key word here, might require ongoing clinical care even after being discharged from the hospital. 111 patients hospitalized for COVID-19 were readmitted to the same hospital within 2 months. And this is data that is actually tracked by CMS. Patients who were readmitted were more likely to be 65 years old or older, have a chronic medical condition, have been hospitalized within 3 months preceding the first COVID-19 hospitalization, and have been discharged to a skilled nursing facility or with home health care. There's a lot of material to cover. I can't imagine how much everybody gets slammed with COVID-19 material on a regular basis. And so how do you go through all this material? How do you pick out what is practical, usable, what's realistic? And so literally there was this wonderful article out of Helio that talked about how do you navigate the COVID literature tsunami. So we have learned enough about COVID-19 to provide effective supportive care for majority of patients with severe illness, provided that healthcare systems are not overwhelmed. And you're beginning to hear about some of our healthcare systems with huge spikes in disease that are becoming overwhelmed right now. In the sickest patients, we have learned that it is an overly exuberant inflammatory response, not direct actions of the virus, that is causing the most damage. And so as oral health professionals, we know the importance of reducing inflammation from periodontal disease and how that affects different systemic conditions. Well, it's also the same here. So we really want to make sure that our patients have good oral health and hopefully better outcomes with this disease. So we looked at the diagnostics. What areas of research have evolved the most rapidly? Well, diagnostics has truly moved quickly. HIV was started, we didn't even know what it was actually in the 80s. We just knew that there was this kind of syndrome that was going along. Rapid testing diagnostics took quite some time to come out. And even though I've always looked at our medical advances as HIV as remarkable speed, how we went from something that was a death sentence to a chronic condition in 10, 15, 20 years as something that's truly remarkable, we're moving faster today because of technology and because of the impact this pandemic is having on the world. Things are moving really quickly, and that's always good to hear. So our diagnostics have evolved rapidly, including point-of-care diagnostics, although there continues to be some supply issues with our PCR testing that are preventing more widespread implementation of testing in some locations. So if you're having a hard time getting PCR testing, let's look to other methods of testing, such as point-of-care, to let people know their status so they can protect themselves and protect others. With regards to therapeutics, we had a big advance that we'll talk about recently, but we also learned from a centrally controlled clinical trials, and these are double-blind placebo trials, such as the recovery trial in the United Kingdom, tend to be more valuable than retrospective or observational trials. So thanks to the recovery trial, we do know that dexamethasone, a steroid, is beneficial in critically ill patients requiring ventilatory support. What areas of COVID research have evolved most rapidly? Novel adaptive trial designs can quickly evaluate multiple agents and combination therapies, which is what we've done in HIV all these years. We started with one therapy, it worked for a little bit, but not really, and then we added another. We found that it was triple therapy that actually worked. And so we're really looking at combination therapies to manage COVID-19, and the NIH-sponsored ACTIV studies are looking at that. And we all know, if you've turned on your television or your computer, that vaccine development has really progressed remarkably quickly, and that's a blessing. Areas in need of more research. What is the influence of prior exposure to the endemic seasonal coronaviruses? Does it make, when you get coronavirus, does it make it less aggressive? There's evidence now that suggests prior exposure may be associated with a milder illness, but other observations suggest the potential for detrimental cross-reactive immune responses. So again, things that we sort of need to figure out. We also need to understand the impact of viral inoculum. Sometimes I'll refer to that as viral load or unclinical outcomes. Could it be that more recent COVID-19 cases are less likely to be fatal because people are being infected by lower doses of virus as a result of social distancing and wearing a mask? Could it be that we know certain things from translational research that will help with better outcomes? But viral load or viral inoculum, how much you get infected, could determine how sick you are, but we don't know that yet, and that's one of the things that we're looking into. We do know about transmission of COVID-19 in households. This was a CDC MMWR. And when it comes to looking for getting through that tsunami of literature, the CDC MMWR has been a trusted piece of literature since I've been a student. It still is a trusted piece of literature that comes out on a weekly basis. These are remarkable studies, and I'm just going to go over a few of them. So what do we know about the topic? Transmission of COVID-19 occurs within households. However, transmission estimates vary, and the data on transmission from children is limited. What does this report tell us? Well, from a prospective household study with intensive daily observation for greater than 7 consecutive days indicate that transmissions of SARS-CoV-2 amongst household members was frequent from either children or adults. So we knew that there was household transmission. Now we know it can be frequent. What do we learn from this? So we know that household transmission is common and occurs after illness onset. Persons should self-isolate immediately at the onset of COVID-19 symptoms, at the present time of testing as a result of high-risk exposure, or at the time of a positive test result, whichever comes first. All household members, including the index case, should wear masks within shared spaces in the household. So you need to take the same precautions that we're taking in the dental setting. We keep our masks on while we're in the dental clinic, unless you're in my office right now, which is closed. We have our eye protection on when we're in the dental clinic. So if you're in a household with someone who has a positive COVID, they need to wear a mask. You need to wear a mask. Birth and infant outcomes following lab-confirmed SARS-CoV-2 infection in pregnancy. And this just came out and is a little bit of contradictory to what I said earlier, which is definitely why I'm bringing it up today. What do we know? Pregnant women with SARS-CoV-2 infection are at increased risk for severe illness compared with non-pregnant women. Adverse pregnancy outcomes such as preterm birth and pregnancy loss have been reported. What do we know from the report? Amongst greater than 3,900 infants with known gestational age born to women with SARS-CoV-2 infection, about 13% were preterm, as defined as less than 37 weeks, higher than a national estimate of about 10.2%. About 610, 21.3% infants with testing results, 2.6 had a positive SARS-CoV-2 result. So the child did get this from the mother, primarily those born to women with an infection at delivery. So how this transferred, how the vertical transmission occurred is something that we really do need to look into more. So the findings can inform clinical practice, public health practice, and policy. It is important that providers counsel pregnant women on measures to prevent SARS-CoV-2 infection. In the dental office, we have a lot of 50% of the dentists in America now, I believe, are women. We have a lot of female dental assistants and a lot of our staffs are made of women. We need to protect them. That is our result and our responsibility. So again, following standard precautions that now take into consideration airborne transmission is important. We want to protect our pregnant women. We want to protect our non-pregnant. We want to protect everybody. And we definitely want to make sure that there are no bad outcomes. So by following the infection control guidelines that the CDC has come out with, that the ADA is recommending, that other programs are recommending, that OSAP has a wonderful foundation for, these kinds of things will help protect all people. And again, that is so very much important. The references for these two cases, again, are here, so you can look at them for yourselves. Now we're going to look at exploring lessons learned on applying safety and quality skills. We've all done some new things to protect our staffs and our patients. So 4 lessons to help clinicians lead their organizations to success. And these are leadership lessons. you should have a continuous improvement process. So it could be anything from managing how you manage all the infection control things that you're doing. Remember, at one point, I believed I talked about the On Track, which is a reminder system to make sure that somebody is screening patients, that patients are being called in advance and asking about symptoms, that we're changing and checking our ultrasonic cleaners appropriately. But we've done formal, continuous quality improvement. One of the projects that I've run out of this program for several years is looking at antibiotic stewardship and, of course, opioid stewardship. Antibiotic stewardship, to me, is sometimes the bigger challenge. Concentrate on the immediate and highest priority concerns using data and informatics to inform decisions, again, based on infection control. During a crisis, high-impact leaders are good at listening. I'm good at talking. I'm working on good at listening. You have to be able to listen to your frontline staff to identify issues that are most important. What are their concerns? How can I address their concerns? And what are the most important concerns to tackle? And then use data and information to evaluate your impact of your changes. Did this impact make the staff feel more comfortable? Did we have an increase in patient volume? Just looking at some of the different things, and this is actually a wonderful presentation that came out of the Harvard School of Medicine. Translate the research that we're learning into meaningful action and then disseminating this information rapidly, which is why I'm proud to be a part of the Henry Schein COVID series. We too try to get, in dentistry, we too try to get the information to you as fast as we can, and then it stays online so you can review it. So, to illustrate the concept of action, one of the lessons learned came out of Italy. Remember, we had a start in China, and then Italy had this huge outbreak, and how did they deal with it? And their cases were overwhelming their hospitals at the beginning of the epidemic. Clinicians in Italy discovered that moving the COVID-19 patients experiencing respiratory distress into the prone position, or lying on their stomachs, improved their lung function and led to better outcomes. So this approach was rapidly shared and adopted by all hospitals. We know it is crucial to create proning teams to put patients in the best position for full recovery. So just something as simple as an observation that patients lived longer, had less respiratory distress by having them in a prone position, found that out in Italy. It was disseminated around the world, and it's something that we're doing in America now. Lesson 4. Always remember to keep the patient and family at the center of our efforts. I think that's what we do. We went into this field to help people, to eliminate pain and infection, to improve quality of life, and to give people that wonderful smile and reduce disease. Regardless of the conditions and challenges we face, it is important that we always go back to thinking about how our work affects the patient. We not only need to be safe, but we also need to value the benefits of patient-centered care. And I can't stress that enough. That is basically what my whole practice is about. What can we do to meet the needs of the patient where the patient is at? So let's go to something a little bit practical for the general public, but really for us. A lot of us have been wearing masks on a daily basis. For those of you who started at the beginning of this series, I believe it was towards the end of March, you might have noticed I had some facial hair. My facial hair is gone, so I get a tight fit for the N95. I think that's something we really need to review at some point, because you can see people with beards. You can't get a seal on an N95 if you have facial hair. So mine is gone because I do go in the clinic and I work, and I want to make sure that I don't bring I don't get the disease, and I don't bring it home. But what about Maskne, a new term that was coined during the pandemic to describe acne under facial masks? It is at an all-time high with the general public, and especially us with healthcare providers. This type of acne is called acne mechanica. The term refers to skin irritation from excess pressure, heat, and rubbing against the skin caused by a mask. When the skin is constantly rubbed, it becomes rough and forms acne-like bumps, or can form acne-like bumps. Masks can worsen existing skin problems or cause new ones. Additionally, hot, humid weather, which we have just passed, can create the perfect storm for bacteria, causing acne to grow on the skin. So this is a dermatologist who really came out with some great ideas on what we can do or what people can do to improve skin health under the mask. 1, wash your face with a gentle, mild, soap-free cleanser that will remove excess dirt and oil that clogs pores and causes breakouts. 2, apply a fragrance-free moisturizer to keep the skin hydrated, which will act as a barrier between your skin and the mask and friction reduction. And we actually have this at the hospital. Look for ingredients like that are listed here, including hyaluronic acid, which can provide additional protection. Avoid wearing makeup under the mask, as this can contribute to clogged pores and leave residue on the mask. I will tell you what I really am seeing a great deal of are a lot of eye makeup on my female staff, because that's how they can do their expression, because it's not messed up by the mask or their goggles or their shields. If wearing a cloth mask, wash it daily. And that's something I know is hard for people to understand. But you need to wash those cloth masks daily. For medical masks, ensure they are changed daily, especially if they're dirty, change them before. Sweat and bacteria and oil accumulate on masks. If you have the option for a cloth mask, choose 100% cotton, which allows the skin to breathe and are less likely to cause breakouts when compared to blended or synthetic materials. The doctor also says there are other simple steps you can do to improve skin health. Don't touch your face like I just did. But you also have to worry about contact dermatitis. And that is something I saw before COVID with just wearing a mask. I have a wonderful dentist on faculty here who has contact dermatitis with a certain type of face mask. So we had to get a non-allergenic type for this provider. And then I basically switched the whole staff over to them. There are allergic reactions to some of the components in the mask, such as dyes, rubber, and fabrics. This presents as a rash and can be itchy. If this occurs, using a very, very mild topical steroid, a very mild over-the-counter hydrocortisone can be helpful. Strong steroid can scar skin tissue on your face, so it's a mild steroid. Or listen to whatever your dermatologist has to say, because they're a lot more knowledgeable when it comes to treating this than I would be. If your skin issues persist trying these steps, it's important to seek medical attention. Go to a dermatologist, go to your primary care provider for additional treatment options, and they'll really help you through the different steps. So we did have some remarkable news. Pfizer and BioNTech report very promising results from their COVID-19 vaccine. The drug maker Pfizer announced this past Monday that an early analysis of its coronavirus vaccine trial suggested that the vaccine was robustly effective preventing COVID-19. When I say robust, when you see 90% effective, that is remarkable. That is a much higher number than I think even the most positive-looking people would have come up with. This was developed in combination with a German biotech, and this actually, Pfizer did not take any of our federal money through the Warp Speed project to go through this, so they've done this on their own. Their analysis found the vaccine was, as I said, more than 90% effective in preventing the disease amongst trial volunteers who had no evidence of prior coronavirus infection. If the results hold up, because this is an interim analysis, if the results hold up, that level of protection would put it on par with highly effective childhood vaccines for diseases such as measles. Another important issue is there were no serious safety concerns observed at this point. So we have excellent interim data, beyond our best hopes interim data, and no serious side effects. Putting in context with other vaccines that we do, as I mentioned, and the Pfizer vaccine is a 2-dose vaccine, 21 days apart. One of the issues that we're going to have with this vaccine is it has to be stored below zero at a significant cold temperature. And how we'll get this to around the country is going to be a challenge. But we are good at overcoming challenges in this country. We have a history of overcoming challenges, which is one of the reasons that makes North America so special. Measles is a 2-dose vaccine with 97% efficacy. Smallpox, 95% efficacy. Chickenpox, 92% efficacy. Seasonal flu, 40 to 60% efficacious. There's a rumor out there that we have to confront every year. The flu vaccine does not give you the flu. You might catch something, it's during cold and flu season. There are allergies that happen. The flu vaccine does not give you the flu. The coronavirus vaccine using this new technology does not give you coronavirus. I just want people to have confidence in vaccines because there has been a decrease in some areas of confidence in vaccines, anti-vaccination folks. If we're going to return to a level of normal, then we have to have a vaccine against this pathogen, and we have to take the vaccine once it's available. Pfizer plans to ask the FDA for emergency use authorization for this 2-dose vaccine later in November, after it has collected the recommended 2 months of safety data. By the end of the year, it will manufacture enough doses to immunize 15 to 20 million people. Let me put this in perspective. There are 350 million Americans. So how are we going to get everybody vaccinated? It's going to take a period of time. And hopefully some of the other vaccines will also show promise, so we're just not limited to one company and one vaccine. Independent scientists have cautioned against hyping the early results before long-term safety and efficacy data has been collected, and I'll be there too. But the interim data is remarkably promising, and I have to show excitement about that. And no one knows how long the vaccine's protection will last. Remember, new disease, new pathogen, new medications, new vaccines. Speaking of new medications, the FDA authorized monoclonal antibody for the treatment of COVID-19. The FDA issued emergency use authorization for an investigational monoclonal antibody therapy, bamlanivimab, and this is going to take me a while to say correctly, for the treatment of mild to moderate COVID-19. This medication is authorized for patients with positive results of direct SARS-CoV-2 code viral testing who are 12 years of age or older, weighing at least 88 pounds, and who are at high risk for progressing to severe COVID-19 and or hospitalization. So this includes those who are 65 years of age or older and have certain chronic medical conditions. So this is for the treatment of mild to moderate disease. This is not for the treatment of severe disease for already hospitalized patients. Monoclonal antibodies are laboratory-made proteins that mimic the immune system's ability to fight off harmful antigens such as viruses. Bamlanivimab is also a monoclonal antibody that's specifically directed against the spike proteins that we see in all the pictures of SARS-CoV-2, designated to block the virus's attachment and entry into human cells. While the safety and effectiveness of this investigational therapy continues to be evaluated, as will all new therapies, as will all vaccines, this medication was shown in clinical trials to reduce COVID-19 related hospitalizations or emergency room visits, and our emergency rooms are already being overwhelmed in patients with high risk for disease progression within 28 days after treatment when compared to placebo. So if you get this medication and you're a mild disease, I think you might know that there was a relatively famous politician who had COVID. He was at a super spreader event. You see him on TV a lot. When he went into the hospital, he got monoclonal antibodies for early treatment. That's what standard of care is looking like it will be at some point soon. A benefit of this treatment has not been shown in patients hospitalized already, so severe illness. Monoclonal antibodies such as the one we're discussing today may be associated with worse clinical outcomes when administered to hospitalized patients with COVID-19 requiring high-flow oxygen or mechanical ventilation. So basically, we have seen in the last 2 weeks some remarkably encouraging advances. We have a vaccine, according to Interim data, that is showing to be 90% effective and not having any significant side effects. We are waiting for the full effect at the end of the full study at the end of the month. But remember, these will be studied over a period of time. Also, even though that this particular vaccine will only be available to 15 to 20 million people, healthcare workers, especially dentists, are considered frontline and will be at the top of the list, as would people over 65 with underlying medical conditions. We have a treatment for early disease that could help prevent people from going to the hospital and people going to emergency rooms with COVID. So again, we're seeing some advances that we haven't seen before. On the other side of the on the other side of the column, we know that we're seeing a spike in cases right now, that we know that we need to take all the protective measures we can take both in the dental setting and outside the dental setting. A dear friend of mine who owns an office, a hygienist, went to visit family, came back, had COVID. So then they had to go through COVID protocols. So again, I'm not discouraging people from visiting family or anything of that sort, but I do think we need to mask when appropriate. We need to wash our hands when appropriate. We need to physically distance until we get all of these options available and we can move forward. As always, it's a pleasure having this time to speak with you and give you some of the latest information from the information tsunami that we go through. I look forward to it, but I will say that this will only be the only presentation in November, and there will only be one in December due to the holidays. If you have questions, please feel free to turn them in as always. And now I'll turn it back to Gary per usual. Thank you.
Thank you very much, Dr. Reznik, for that update. If you have any questions, concerns, or suggestions for future topics, please email us at webinars@henryschein.com. Also, please subscribe to our YouTube page by clicking the button below. I'm Dr. Gary Severance with Henry Schein, and as always, until next time, stay safe and stay informed.